So this is a little overview, a picture I often show people of the stages of bladder cancer. I'm not sure if you can see my cursor there, but this is showing basically the bladder being almost like a balloon. So the urethra here where you pass urine at the bottom, and then they're showing the layers of the bladder. So the red in the middle is where the urine usually is, and then showing the surface or like the skin of the bladder almost. Then the next layer with the pale pink and the little red dots is the muscle, and then the fat around the outside. And then these images showing the various stages within the bladder. So the earliest possible being in the bottom left being the TIS, which is the in situ cancer cells. So that will just be when the cancer is growing in just this surface, but not really forming much of a tumour yet. And then going through TA, where it's kind of protruding into the bladder, but not really getting any roots to go any deeper. And then as you go around, getting deeper and deeper into the bladder. So the T1 growing into a little bit under the surface, and then the T2, 3, 4 around the outside, getting deeper into the bladder and even through the bladder wall. And this is really important when we look at what the best treatment's going to be. I kind of liken those very early bladder cancers like the TIS, the TA and the T1 almost to being like a skin cancer on the surface. So the primary role being to remove them, but they do have a chance of coming back. So as you may know, if any of you have got the early kind of bladder cancer, all of those early ones are kind of bundled together in what's called non-muscle invasive bladder cancer. So they're the ones that are on the surface. They might have some very early roots into that first layer, but they're not going deeper into the muscle. And also known as, you might see written down or read about, superficial bladder cancer is kind of the same thing, but the terminology was changed a little while ago. So the treatment for these non-muscle invasive bladder cancers primarily is to have them removed. So seeing the surgeon, having a cystoscopy and then removing anything that they can see. And then based on how aggressive they look is whether it might be best to have some treatment given into the bladder afterwards to try and reduce the chance of the cancer recurring. And that's called Intravesical, which just means into bladder treatment. So going back to this picture, it's these ones here, the TIS, TA and T1 that are included in this group of the non-muscle invasive or superficial bladder cancers. And once it gets further with some deeper roots, the treatments are quite different. So I'll separate those two sections out. So when we look at these treatments given into the bladder, and as I understand from Chris and Carly, a lot of the questions are about some of these treatments. The two things we commonly use, one is BCG, which we'll talk more about, or chemotherapy drugs. But it's not traditional kind of chemo. It's not like you're going to get the side effects of someone who has an intravenous drip and chemo going into the bloodstream. It's just it's going in just into the bladder. So main symptoms are kind of irritation of the bladder. And there's no hair loss and virtually no nausea. Sometimes there can be a little bit of fatigue, but it's not like having standard chemotherapy that people would have for other cancers. Method of delivery, however, is exactly the same. So it involves coming into, we do them through chemotherapy suites, but they're also done through ambulatory care units, or some people do them in surgical recovery, where you don't have an anaesthetic for the treatment, or not a general anaesthetic, but you do have a little bit of local anaesthetic given through the urethra just to kind of numb it so you can put the catheter in without it causing too much discomfort. And as many of you probably had the BCG know, is that it does cause a fair bit of irritation of the bladder, and that occurs much more so with the BCG than with chemo drugs. Treatments can actually be prescribed by your urologist or an oncologist. So I'm aware that it differs quite a lot from one hospital to another. In our centre, there's been an arrangement many years ago before I started working between the two teams that the oncologist would kind of run the Intravesical treatments. But in some places, I know the surgeons actually do this themselves or have a facility where they can actually do this. Carly, what happens at Macquarie? Do you guys do it, or does it go through to oncology?
I think oncology does it at Macquarie, but in the public hospital, urology does it.
Yeah. So whenever we kind of all talk as a group, there's a lot of oncologists that have had nothing to do with these treatments at all, depending entirely on where they work. And I know
sorry, go on.
No, as I said, I know some private urologists even have the ability to do it in like a room within the consulting suites.
Question. Just going back to the histology slide, what's the difference between high and low grade? Other way. Oh, yeah, there. What's the difference between high and low grade is the question.
Oh, so it doesn't necessarily kind of show it on here, but it's more under the microscope when the pathologist is looking at the cancer cells, and they look at features to see how aggressive it looks. So if the cancer cells look like they're growing really fast, there are some things they can detect when they're looking at the tissue under the microscope that tells you whether it looks slow or fast. And some of that's based on how many cells were actually like dividing and growing at the time of the biopsy. So they can kind of do it to account of, say that 10% or 20% of the cells were dividing and growing at the time the biopsy was taken, or it might look like they're all actively dividing and growing at the time. So the pathologist looks at a couple of things like that to determine whether they think it's looking high grade or low grade, and also how abnormal the cells look. So low grade cancers tend to look more like normal tissue, so they'll look more similar to a biopsy of a normal part of the bladder, whereas the high grade will look very abnormal and might not even look much like bladder cells under the microscope. So that's something that comes back on the biopsy report.
Something else which I'm sure you're going to get to is what's the alternative treatment to people with BCG intolerance. I'm sure you'll cover that soon.
Yeah, so we'll kind of go through that. And also, in more cases than not, it's because we can't get the BCG rather than the intolerance being the main issue, yeah. I'll just go back. Okay. So this is just a little picture showing exactly what's done. And as a lot of you probably know, is they'll say, look, don't drink too much before you come for the treatment, because we're going to put a treatment inside the bladder and going to get you to hold it for a couple of hours. So we want your bladder pretty empty to start with. So a lot of people don't drink much the morning of the treatment or the night before. Number 2 here is they put the little catheter up through the urethra into the bladder. And they'll empty as much as they can of whatever's in there, but then the BCG goes through a syringe or the chemo, however it's given, into the bladder, and then they clamp off this catheter so that it can't come back out. And ideally get you to try and hold it for 2 hours. And so most times that's done while you're still waiting, or while you're still within the hospital or the chemo suite. And a lot of people kind of describe this as being on the rotisserie, so they have to roll around on the bed, and usually it's every 15 or 20 minutes, just a reminder to roll side to side or kind of front to back, so that you're sloshing the fluid around the whole bladder. Because as you can see in here, it kind of almost gets a bit of a bubble, or it pulls away from the fluid, and you can get patches of the lining of the bladder that don't get the BCG solution on them if you stay in the same position for the whole time. So that in some places the nurses give you a little timer and get you to roll around and turn. Other places you just set your own reminder to roll around during the treatment. Then number 4 down the bottom here is, once you've held for however long you can, whether that be an hour or 2 hours, the catheter gets unclamped and all the fluid comes out. The catheter goes out, and then you go home again, usually having been about 2.5 to 3 hours in having the treatment. In younger people that are possibly very fit and they're able to kind of make their way home and not be too busting to go to the toilet, sometimes after 1 or 2 treatments, you might have the solution put in the chemo suite or recovery and allowed to go home and do the rolling around on your own bed, and then go to the toilet at home. And that's usually done for the first time you're having the treatment, is done once a week for 6 weeks. So these are the kind of schedules of treatments you can have with intravesical therapy. So in some cases, if you're known to have like a low-grade cancer, and the timing of this is kind of that the surgeon's done 1 biopsy, they know it's low-grade and they're going back just to clear the bladder, they might ask to have a single dose of chemo put into the bladder straight after that cystoscopy. So basically while you're in your recovery or the day that you're in afterwards, you can have a single dose given straight into the bladder of a drug called mitomycin. And in some people, that actually stops the cancers progressing to high grade or stops others coming back, and might be all that you need. And in the people that I've seen have this, I'm not often involved with the single doses. It's usually the surgeons. They kind of hardly ever know it's been done. They're just in recovery, having their waking up to their anaesthetic and everything, and this treatment's done at the time, so it doesn't really affect them very much at all, and might prevent it progressing and needing the more intensive treatments. But for the majority of people that I see, they come to see me because they've been found to either have a low-grade cancer that keeps coming back, or it's kind of more aggressive and it's more of a high-grade cancer, and they're needing a longer course of treatment. And most people have what the first part's called induction, and that's when, as per the previous slide, where you do one treatment per week for 6 weeks, and it's usually the same drug every week. We don't kind of change between the weeks unless there's problems with it. At some stage, you might need a week off if you're getting lots of side effects or struggling to hold the fluid in the bladder for the 2 hours, or you might get a urine infection during it. And usually at the end of the 6 weeks, you then go and have a cystoscopy to check what the next step is. And occasionally this induction 6-week course might need to be repeated. And that's if at the next cystoscopy there's still something growing, or down the track something more aggressive grows, we might need to give the whole 6-week block again. But most people would have the 6, have their checkup and be all clear, and then go on to maintenance treatment. And I know there was a few questions around maintenance, but it does vary quite a lot depending on the exact pathology, so how many tumours were seen, how aggressive they were. But typically, which I think is showing on next, in more detail on the next slide, the shorter duration for the low-grade cancers is usually up to 12 months of maintenance. But if it's high grade or there's lots of tumours, we might go out to 3 years, depending on how the treatment's tolerated. And might need to change the drugs or the schedule of the treatment if it's not tolerated very well, or obviously if more cancer's picked up at the next cystoscopy. So this is a kind of a summary of from the European guidelines of how long the treatment should go for, depending on what that pathology report shows. When you see the surgeon, they go through what was found. So in people that are considered to be low risk of something coming back, and that can be that there was just a single cancer seen that was low grade, and that there was no carcinoma in situ, which is the cancer cells growing in the surface, and no invasion into the deeper parts of the bladder. They may just have that single dose of mitomycin that I mentioned just at the time of their cystoscopy, and might not need anything further. And then I'll just kind of jump down to the high risk, because you might notice in that middle box on the intermediate is kind of just the people that fall in between the low and the high risk. So with the high risk, it means that there's been a high grade cancer found, or it's growing a little bit deeper into the deeper levels of the bladder, or that it's come back multiple times. And in that case, we would consider it to be a high chance of something coming back down the track if you don't do anything other than surgery. And that's when we go through that 6 weeks of BCG induction on the right-hand column there, and between 1 and 3 years of the maintenance treatment. And for the people that fall in the middle, that's when we will often give just a shorter course of the maintenance. So someone who just keeps getting the low-grade cancers, or doesn't have any of those high-risk features, they might have a shorter course of maintenance and still be quite successful. And the reason for giving the maintenance afterwards is the induction, I kind of think, is the most important part of the treatment, but there's been quite a few studies shown that if you have the maintenance as well, it actually further reduces the chance of something coming back, and that's why we continue the treatment afterwards. And obviously at the bottom of the table, some people unfortunately fall into this highest risk group where the cancers just keep growing despite the BCG, and they might have had BCG and then tried a chemo into the bladder as well, and the cancers just keep getting worse. In that situation, we may need to look at more radical treatments like taking the bladder out with a cystectomy, or possibly considering radiation to the bladder, or a combination of chemo and radiation. So what drugs do we use? So most commonly we do use BCG, and as a lot of you may know, that's a small dose of a bacteria called Mycobacterium bovis. So it's basically giving like a little tiny dose of a urinary tract infection. And the way it works is it's kind of inflaming your bladder wall. So it's making your body think it has a urine infection, or it actually is giving it a tiny infection that hopefully it stimulates your immune system to go to the bladder to try and clear that infection and activates the immunity to kind of kill the cancer cells itself. So it was one of the very early forms of immune therapy, in the hope that if we can make your body realize the cancer shouldn't be there, then hopefully your body will keep, basically mopping them up themselves, and that down the track, if little things start to grow, that your body knows that they shouldn't be there and tries to fight them themselves. We do sometimes use a chemotherapy drug into the bladder instead, and there can be quite a few reasons why we might do that. One might be that there's no BCG available in the world, which happens quite frequently. It's been a big issue again this year, unfortunately. And I think there's a lot of reasons for the lack of supply. Sometimes it can be that from what I understand from the pharmaceutical companies, that a whole batch of the bacteria didn't grow properly, or that the potency wasn't quite right. So you kind of get a month or two where there's just no BCG available to distribute. We think that COVID probably impacted a little bit this year, and that shipping it into the country became more difficult. And we've had to use a lot of different strains of the BCG. So lots of different countries make their own kind of BCG. So sometimes it might vary midway through the treatment, or needing to start on a strain that we don't know quite so much about. But the chemo might be used, so if we don't have the BCG, or maybe you've had BCG before and it's not working, so we want to try something different. So the chemotherapy works a little bit differently. So that's not stimulating your immunity. It's a treatment that's trying to basically directly poison the cancer cells to kill them, stop them growing and dividing. And if you kill them off, hopefully they can't, get any worse within the bladder. And the treatments that you've probably heard about is the mitomycin that we talked about before, that you can give as a single dose after a cystoscopy. You can use as a course of treatment like the BCG. So you could give it like as the 6-week treatment, and then the maintenance with the mitomycin. If anybody here has had that, you might know it's a bit of an issue with the PBS, or the government doesn't pay for mitomycin. So sometimes there's an out-of-pocket cost associated with that. Or another drug we use called gemcitabine. Gemcitabine is a drug we use quite a lot in people with more advanced bladder cancer, given intravenously, but if you give it into the bladder, it seems to work quite well as well. And I know one of the questions was about using a combination of 2 chemo drugs together. And that's giving basically one drug after the other, still both straight into the bladder, but needing to put one drug in, wait for the 2 hours, let the drug out, and then give the second one. This is a reasonably new treatment, and it was presented when I went to a conference in San Francisco just before the world shut down, where they were looking at techniques and treatments to use if there wasn't BCG available, or for people who the BCG hadn't worked and they really didn't want to have their bladder out. So the 2 chemo drugs given together, we hope might be more potent and more effective than giving one drug on its own. But it is a reasonably new treatment, hasn't been used in large numbers of people, but certainly in small trials with a few hundred people, it seems to be quite effective in the people where we couldn't get the BCG or had some reason for not having it. But it makes treatment obviously twice as long because you have 2 infusions. Yeah.
And so is the synergistic effect supposed to be more effective?
Yeah, I'm not sure whether it's synergistic through the drugs with each other, or that you're just kind of the 2 drugs being quite different and killing cells in a different way. Just like when we give combination chemotherapy intravenously, you're basically kind of trying to prevent cell growth by attacking in 2 different methods. Yeah, I'm not sure whether they kind of activate each other, or whether it's just kind of the cumulative effect of giving 2. But we've started trying to get that approved at a few of our hospitals because of the BCG shortages.
But we don't know the long-term benefits.
No, it seems to have been quite a recent thing that's done in only small numbers of people so far. But we have got a few people having it at St George for either the recurrence of the cancer was really small, so it was kind of too extreme to go straight to removing the bladder, or that we couldn't get BCG and it was high grade, and we felt that it'd be more effective than one drug on its own.
Do you think there's superiority to mitomycin, the combination gemcitabine docetaxel?
Yeah, I haven't seen that says they're kind of compared head to head. We know that mitomycin versus BCG, the BCG certainly wins. Not by a huge amount, but probably around that 5 to 10% better than the mitomycin. And I would assume that the combination of the two drugs would be more effective than mitomycin on its own, but I'm not sure if they've been tested kind of head to head to know that for sure. And some people may have heard about there's a trial being run by ANZUP, which is the Australian New Zealand Urology Group, which coordinate to try and run some trials both locally and coordinating with overseas. And they're doing a trial of giving the BCG and mitomycin in the hope that it might be better than one drug on their own. And that's given as not on the same day. So not like the gemcitabine docetaxel given one after the other on the same day, whereas the trial is alternating them. So giving 2 weeks of BCG, then 1 week of mitomycin. So there might be someone on the chat who's heard of that or had that treatment, and what we hope.
Yeah. Paul in our group, Paul had it. But he unfortunately had to go for cystectomy.
Yeah.
Didn't work for him.
Yeah, it's hard to know. We've probably got about 15 people that have been through it so far. I haven't kind of got a good feeling for whether it seems to be better or worse than BCG on its own. Probably just too soon. But I believe they're about a bit over 50% of way through recruitment. So I think there's about 250 people maybe that are on that trial so far.
There was another question, just how often is maintenance?
So if I've got it, I thought I put it somewhere. No. So usually is
it monthly?
Yeah, there's a few different schedules. So some studies gave 1 treatment per month as the maintenance, but more commonly it's given as cycles of 3, so that you do the 6 weeks in a row, and then the 3-month mark doing 3 treatments, at the 6th month mark doing 3, and then going out to each 6 months. So I almost need to draw it out, but it's 3 consecutive weeks each 3 months initially, and then if everything stays clear, going out to 3 weeks each 6 months. And then it gives people bigger recovery times off treatment, I find, whereas the monthly, you kind of don't quite get over the cystitis kind of symptoms of urinary frequency and burning by only having kind of 3 weeks in between. But both schedules equally give the same amount over a 12-month period.
Patty, there's another question. If BCG, if cancer comes back after the BCG, can you then go and do BCG and mitomycin as the next option?
For the trial, they're using it as the first treatment. So it has to be people that have not had any treatment into their bladder before. We can do the other ones though. So if I go back to, so if you had just the 1 course of 6 BCG and something comes back, we would prefer to give another 6 weeks of the BCG, because some people it just takes up to 3 or 6 months for your immune system to get adequately turned on. So we'd usually try another 6 of the BCG if everything was tolerated okay. If it wasn't, for example, lots of burning and stinging and urinary frequency and just can't do another round of the BCG, we would then go to usually one of the chemotherapy drugs. And most of the time we're giving either the mitomycin or the gemcitabine on its own, but obviously try and get a feel for whether this combination gemcitabine docetaxel might be good, especially in someone who's kind of younger, fitter, haven't had too many bladder symptoms from the BCG. But yeah, it doesn't automatically mean that after 1 round of BCG that it's failed and you have to move on to something else. We give it a little bit longer usually. And I've also seen plenty of people who've had a course of BCG like 5 years ago and then something's come back and we've retreated again and that's worked again. Obviously, a lot of people wanting to know exactly what the chance of their cancer coming back is. And it's reasonably complicated because it depends on how big the cancer was, how many, was there just 1 or was there multiple inside the bladder? And this is just one of the calculators that can use. And you don't need to register or anything for this. Hopefully this works by clicking on it and showing you. There's lots of companies making them, but this is where it's quite easy little drop-down calculator without all the ads, if we can stop them, running, where you can kind of just pick whether, if there's just 1 cancer, if we know how big, usually it's just bigger or smaller than 3 centimetres. Usually the surgeons will know that, or it might be on the report. And then if it's come back before or not. So is this the first time that a bladder cancer has been found, or has there been multiple found and this is like the third or fourth time it's come back? You kind of pick on there. The stage, so the TA being no evidence of growth into those lower cells of the bladder, or maybe it has gone a little bit deeper. So this is off the pathology report. So I sometimes do these little calculators with patients, so because you need the pathology report to do it. And then also whether there was the carcinoma in situ, so those cells growing in the surface, and then just whether it was high grade or low grade. We don't really ever see this grade 2 reported. We seem to get low and high. And then it calculates down the bottom here what the chance of your cancer coming back is. So the dads don't want to stop. But looking at, in 1 year, so this is assuming that the only treatment was the cystoscopy. So if you didn't kind of do any of these intravesical treatments, what's the chance of it coming back? So these are kind of showing at the 1 year mark, the 38% chance of something growing back, at 5 years being out to 62, and progression is it getting worse at that 1 year. So recurrence is just growing back again, but not necessarily being more aggressive. And then there's ones down the bottom, the progression being, does it learn to grow deeper roots and become a more serious problem? But yeah, there's lots of different companies that do these things, and it gives us an idea of the chances. And obviously, if you can see that, look, there's a 50% chance of something coming back, well, then it's definitely worth having one of the treatments into the bladder afterwards to try and reduce that. And it seems to be that doing a course of the intravesical treatment approximately halves the recurrences. So if there was a 50-50 chance, it might take it down to more like a 25% chance something would come back. But it's quite hard to completely estimate that for everybody, just because it does vary so much. So if you kind of play on here and you go through and say, well, there's actually 8 tumours, well, that makes a very big difference. So I kind of go on a rule of thumb of about halving the recurrence rate by going through the BCG after. So obviously it doesn't take it away altogether, but certainly drastically reduces the chance.